Imagine your child is having, up to 30 violent seizures in a single day.
Oh, wow.
Yeah. And you've run through the absolute gauntlet of standard anti-seizure medications.
Oh, right, the usual suspect.
Exactly. Valproate, levetiracetam. And they've either failed completely or the side effects have turned your child into a ghost of themselves.
Which is a heartbreaking reality for so many.
It really is. So out of sheer desperation, you try this radical, mathematically precise metabolic intervention.
The ketogenic diet.
You got it. And miraculously, it works. Within 2 months, the violent flexion spasms are cut in half.
That's a massive reduction.
Huge. And the chronic severe drooling, it just completely stops. It feels like you finally found a miracle, you know? But then right at the 3-month mark, your child's body begins to catastrophically shut down.
Oh, no.
Yeah. They develop this profound, unrelenting weakness. The medical team tries fluid therapy. They tweak the macronutrients, but the biological strain is simply too much.
The systemic toll is just too high.
Right. You are forced to stop the diet, sacrificing the seizure control just to save your child's life.
That razor's edge, that agonizing balance between neurological control and systemic collapse.
Yes, that is the daily reality of treating PURA syndrome. Welcome to this audio deep dive, tailored specifically for you, the parents, the carers, the educators, navigating a PURA syndrome diagnosis.
It is a profound tightrope walk, and I'm so glad we're doing this deep dive today.
Me too. Because today's goal is to take a massive stack of really dense medical literature and translate it into a practical guide for you.
Right, because the research is evolving at breakneck speed.
It really is. We're pulling from clinical phenotype studies, in-genre reviews, molecular research from the Journal of Medical Genetics, specific case studies like that ketogenic diet one we just mentioned.
And we also have those highly specialized perioperative guidelines from orphan anesthesia.
Exactly. So we have all this source material, and the mission here isn't just to recite data. We want to translate the biology into a tactical advantage for your home or school.
Because what's fascinating here is that while PURA is incredibly complex, the medical community's understanding of its specific electrical footprint is growing rapidly.
Yes, and knowledge is absolutely the most powerful tool you can have in your daily caregiving toolkit, especially when you consider the statistics.
They are daunting.
They are. The literature universally points out that epilepsy affects more than 50% of individuals with PURA syndrome.
Half. More than half.
Right. And what makes it so incredibly scary is that these seizures are notoriously refractory.
Meaning they resist the very medications designed to stop them.
Exactly. Which forces you, the listener, into the role of an amateur neurologist, an emergency responder, and a medical advocate, often overnight.
It's a massive burden.
Yeah.
And it requires an entirely different level of understanding. We aren't going to spend time today defining what a protein is or, what a basic seizure looks like.
Right. Our listeners already know those realities intimately.
Exactly. Instead, we're going to look under the hood. We need to dissect the specific types of electrical storms common in this syndrome.
And understand the biochemistry of why they happen in the first place.
Right. And we also need to isolate the impostors.
Oh, the impostors. The movements that look like seizures, but are actually entirely different neurological misfires?
Yes. And finally, we'll use the clinical guidelines to construct an ironclad biological defense protocol for your home and school environment.
So let's jump right in. The first step in building that defense is understanding the landscape of the battlefield.
The root cause.
Yes. The root cause of all this volatility traces back to a specific address in the human genome, the 5q31.3 locus on chromosome 5.
Right. A mutation or deletion at that exact spot knocks out the Pur-alpha protein.
And looking at the Journal of Medical Genetics data, Pur-alpha isn't just some minor structural component.
No, not at all. It's a highly conserved master regulatory protein.
So what does it actually do?
Well, it is responsible for shuttling messenger RNA directly to the synapses.
Okay, so if we trace the mechanics, why does a failure in RNA translate into an explosive electrical storm in the brain?
To understand that leap, we really have to look at how a neuron builds its connections.
Right, especially during early development.
Exactly. When a brain is developing, particularly during those critical early stages of neural cell proliferation and dendrite maturation, neurons are rapidly forming complex networks.
The dendrites being those branching structures that receive electrical signals.
Correct. And they require highly specific local proteins to function correctly.
And where do those proteins come from?
The nucleus of the cell creates the blueprint for them. in the form of messenger RNA.
But the blueprint is completely useless if it just sits in the nucleus, right?
Exactly. It has to be physically transported down the long arms of the neuron to the synapse.
Where it can actually be translated into the ion channels and receptors that govern electrical flow.
Yes. So Pur-alpha is essentially the molecular courier.
It binds to the mRNA and navigates the cellular highway.
It delivers the blueprints directly to the construction site at the synapse.
Wow, so it really is the critical courier.
It is. If Pur-alpha is missing or defective due to the genetic mutation, that local transport simply fails.
So the mRNA never makes it to the synapse in sufficient quantities.
Right. And as a result, the local scaffolding, the ion channels that regulate the flow of sodium, potassium, and calcium, is built incorrectly.
And that messes up the whole balance of the system.
Completely. The balance between excitatory signals, which tell the brain to fire, and inhibitory signals, which tell it to calm down, is fundamentally compromised.
It's kind of like trying to build a massive, complex electrical grid for a booming city, right?
I love that analogy.
Yeah, imagine the chief architectural courier keeps losing the blueprints for the substations and the transformers.
So the local contractors are just forced to guess.
Exactly. They wire the grid without the proper insulation, without the necessary surge protectors.
And when that biological grid is finally powered on, it is inherently unstable.
Right. It's prone to massive power surges because the physical infrastructure required to dampen an electrical misfire simply doesn't exist.
And what's fascinating here is that because the Pur-alpha deficiency is present in every single cell from the moment of conception, that faulty wiring isn't isolated.
Right. It's not just in one specific lobe or hemisphere.
No, the instability is generalized across the entire brain.
Which explains why the resulting epilepsy is so incredibly difficult to manage.
The brain simply lacks the regulatory hardware to stop a rogue electrical discharge from spreading like wildfire across the cortex.
And the data shows this volatility operates on a highly unpredictable timeline.
It really does.
Like, the clinical phenotype studies indicate that the peak onset for clinical epilepsy in PURA syndrome hits between the ages of 2 and 5.
Which makes physiological sense.
Right, because that is a window of massive synaptic pruning and electrical reorganization in a child's brain.
The system's demands suddenly outpace its faulty infrastructure.
Exactly. But the literature also throws a massive caveat at that 2 to 5 year window.
Yeah, that timeline is just a statistical average. It's not a guarantee.
So it can happen outside that window.
Oh, absolutely. The Jenner Review's data clearly documents seizure onset spanning an incredibly wide spectrum.
How wide are we talking?
We see clinical epilepsy emerging in the neonatal period just days after birth when the initial brainstem and cortical networks are coming online.
Wow. Days after birth.
Yeah. And conversely, we also see the onset delayed all the way into early adulthood.
So you can never really let your guard down.
Exactly. The critical insight for caregivers here is that the electrical vulnerability is a permanent fixture of the brain's architecture.
You cannot look at a 7-year-old child with PURA who has never had a seizure and assume the risk has passed.
Right. The structural conditions for an electrical storm are always present.
Which brings us to the daily reality of observation for you guys listening.
Because the genetic defect is generalized, the seizures themselves are incredibly varied.
Right, we aren't just looking for one specific type of event.
No, the literature points to a cascade of different presentations, typically beginning with myoclonic jerks.
Okay, myoclonic jerks. If a generalized tonic-clonic seizure is a Category 5 hurricane, these myoclonic jerks seem to act like the early lightning strikes.
That's a perfect way to put it.
So let's look at the biomechanics. What is actually happening during a myoclonic jerk in a PURA patient?
Biomechanically, a myoclonic jerk is the result of a sudden, ultra-brief burst of abnormal electrical activity in the motor cortex.
The motor cortex is the strip of the brain that directly controls voluntary muscle movement, right?
Exactly. And because the inhibitory interneurons are underfunctioning due to that Pur-alpha deficiency, a localized cluster of neurons fires synchronously.
Bypassing any regulatory checks?
Yes, and this translates into a sudden, involuntary muscle contraction.
And to a parent observing this in the living room, it's lightning fast.
It really is. It's not a prolonged spasm.
Right, it's a sudden pop.
It is a fraction of a second. It might look like the child suddenly drops a cup they were holding.
Not because they just let go, but because a myoclonic jerk in their bicep or forearm disrupted their motor control.
Exactly. Or it could manifest as a rapid, symmetrical upward jerk of both arms, or even a sharp head nod.
And the insidious nature of myoclonic seizures in PURA syndrome is their frequency, isn't it?
Yes, that's the real problem. While a single jerk might seem minor, these children can experience dozens or hundreds of them in a single day.
Hundreds.
Yes, and that severely fragments their attention. It disrupts their ability to perform fine motor tasks.
And it creates a constant state of neurological microexhaustion.
Right, and that microexhaustion is often the precursor to the major events.
The generalized tonic-clonic seizures?
Yes, these are the highly visible convulsive events that carry immediate physical danger.
So when that localized electrical pop we see in a myoclonic jerk fails to extinguish, it recruits the entire cerebral cortex.
And we get a massive synchronized discharge.
The physiology of a tonic-clonic event must be a state of total neurological overdrive.
It is. In the initial tonic phase, the massive electrical surge causes all the skeletal muscles to contract simultaneously.
And the child loses consciousness instantly.
Yes. Their body becomes entirely rigid, and because the respiratory muscles are locked in spasm, they often force air out through the vocal cords.
Which produces that sudden cry or gasp that is so terrifying for a parent to hear.
It's incredibly scary. Following this, the brain's remaining inhibitory systems attempt to fight back.
They try to interrupt the continuous firing.
Right, and this battle between the excitatory surge and the inhibitory pushback creates the clonic phase.
That's the rhythmic, violent jerking of the limbs.
Exactly.
And the cellular toll of that event is staggering. The brain is consuming oxygen and glucose at an exponentially higher rate than normal.
Just to feel that electrical storm.
Which explains the postictal state, right?
Yes, the recovery period after the seizure stops.
It's characterized by such profound, unrousable sleep. The neurons are essentially experiencing severe metabolic debt.
Exactly. And beyond the metabolic debt, the physical risks during the active convulsing are immense.
Right. The sheer force of the uncoordinated muscle contractions can lead to orthopedic injuries.
And the loss of airway control presents an immediate asphyxiation risk,
Not to mention the sudden drop associated with the loss of consciousness.
which often results in serious head trauma.
These are the acute, critical medical moments that demand swift pharmacological intervention.
Absolutely.
But, the clinical literature emphasizes that not all of these massive electrical events look like a hurricane on the outside.
That's very true. We have to pivot and look at the silent storms.
Absent seizures and epileptic spasms.
Right. An absent seizure involves a highly specific hijacking of the thalamocortical loops in the brain.
So the child doesn't fall, they don't convulse.
No, they simply stare blankly.
Okay, let's unpack this. How does a parent or teacher tell the difference between a child with profound intellectual delay simply daydreaming versus having an absence seizure?
This is a highly nuanced challenge.
Because many individuals with PURA present with profound intellectual disability, right?
Yes, and significant developmental delays. Their baseline interaction with their environment might already be limited.
So they might frequently zone out or appear disconnected just due to simple fatigue or cognitive processing delays.
Exactly. So when a parent sees their child staring blankly at a wall, the immediate terrifying question is, are they just daydreaming, or is their brain currently locked in an absent seizure?
It's an agonizing diagnostic hurdle, so what's the difference?
The differentiation lies in the concept of redirectability versus true neurological unresponsiveness.
Okay, explain that.
If a child with a profound cognitive delay is simply disengaged or daydreaming, their sensory processing pathways are still intact and functioning.
Meaning if you introduce a strong enough novel stimulus.
Right. If you wave your hand inches from their face, if you clap loudly, or if you gently squeeze their shoulder, their brain will register that input.
They'll blink, they'll startle, or they'll slowly turn their head to track the interruption.
Exactly. They are connected, just distracted.
But during an absent seizure,
The electrical discharge completely overrides the brain's ability to process external sensory input.
the thalamus, which acts as the central relay station for all incoming sensory data, is essentially jammed by the seizure activity.
That's right. Waving your hand will do nothing. Calling their name loudly will do nothing.
The child is neurologically barricaded from the outside world for the duration of the event.
Which might last anywhere from 10 to 30 seconds.
And crucially, when the electrical storm abruptly terminates, the child often resumes their previous activity.
Without any awareness that time has passed.
Wow. So if caregivers are observing staring spells that are entirely impervious to physical and visual interruption, they must document it.
Yes, it is a subtle but highly destructive form of epilepsy.
And the destruction isn't just in the moment, is it?
No. The sources outline a very grim long-term trajectory for these various seizure types.
Right. As a child with PURA syndrome ages, these distinct presentations, the myoclonic jerks, the tonic-clonic convulsions, the silent absence seizures, often coalesce.
And they evolve into a devastating umbrella condition known as Lennox-Gastaut syndrome, or LGS.
LGS, that's a heavy diagnosis.
Lennox-Gastaut is one of the most feared diagnoses in pediatric neurology.
Because it isn't just a single disease, right?
No, it's a severe epileptic encephalopathy.
How is that diagnosis actually made?
It's made when a patient presents with multiple concurrent types of drug-resistant seizures, alongside a very specific chaotic brainwave pattern on an EEG.
Known as slow spike and wave complexes.
Right.
Let's break down that term you just used. Epileptic encephalopathy.
It's a critical concept.
It implies that the electrical activity itself is actively damaging the brain's cognitive function.
That is the core tragedy of LGS.
Because in a healthy brain, or even a brain with well-controlled epilepsy, the periods between seizures, the interictal periods, are relatively calm.
Right. And the brain uses that quiet time to form memories, consolidate learning, and strengthen synaptic connections.
That's how a child develops new skills.
Exactly. But in Lennox-Gastaut syndrome, the brain is never truly quiet.
Even when the child isn't having a visible clinical seizure.
Right. Their EEG shows constant simmering electrical chaos. The interictal discharges are relentless.
It's like trying to download a massive, complex software update over a Wi-Fi connection that drops offline every 3 seconds.
The file just gets corrupted. The data never saves.
And a child with PURA syndrome fights incredibly hard for every single developmental milestone.
They might spend years in intensive therapy.
Learning to use an eye-gaze communication device, or learning to bear weight on their legs, or learning how to chew solid food.
But when LGS develops, the relentless electrical static actively disrupts the neural networks responsible for those skills.
And that leads to developmental regression.
The child doesn't just stall. They actively lose the abilities they had previously mastered.
The epilepsy is aggressively dismantling their neural pathways.
This is why early and aggressive seizure management is so heavily prioritized in the medical literature.
The goal isn't just to stop the physical shaking.
No, it is to protect the brain's fragile circuitry from the corrosive effects of constant electrical dysfunction.
But protecting that circuitry requires knowing exactly what you are fighting.
Right, and here is where the clinical landscape of PURA syndrome becomes incredibly treacherous.
Yes, the medical literature is highly explicit about a massive complication here.
Many of the sudden, abnormal, or repetitive movements you see in a child with PURA have absolutely nothing to do with the brain's electrical seizure activity.
And this is huge for parents to understand.
We call these the non-epileptic movement disorders.
They are the great impostors of PURA syndrome.
They really are. And because they visually mimic the jerks, stiffening, and staring of actual epilepsy, they are the leading cause of misdiagnosis.
Which leads to medical mismanagement in this patient population.
If a parent or an uninformed clinician assumes every abnormal movement is a seizure, they will inevitably keep increasing the dose of heavy anti-seizure medications.
And if the movement isn't caused by an electrical storm,
the medication won't stop it,
all it will do is subject the child to toxic levels of neuroinhibitors,
causing extreme sedation and compounding their developmental delays.
While the actual underlying movement disorders remains entirely untreated.
Exactly. We need to forensically isolate these impostors, starting with dystonia and dyskinesia.
Okay, to differentiate these, we have to look at a different region of the brain.
Right. While true epileptic seizures generally originate in the cerebral cortex, movement disorders like dystonia and dyskinesia stem from dysfunction deep within the brain.
Specifically in the basal ganglia.
And the basal ganglia are responsible for smoothing out our voluntary movements and regulating muscle tone.
But because the Pur-alpha deficiency affects the entire brain, the basal ganglia's intricate feedback loops are severely compromised.
Which manifests physically as dystonia-sustained involuntary muscle contractions.
So a child's arm might slowly twist inward and lock rigidly into an unnatural posture.
Or their neck muscles might contract powerfully, pulling their head to one side.
And to a panicked observer, a sudden, rigid posturing of a limb looks terrifyingly like the tonic phase of a seizure.
But the mechanism is entirely different. A tonic seizure is a massive electrical short circuit.
Whereas dystonia is a localized failure of motor control circuitry.
Exactly. And alongside dystonia, we see dyskinesia.
Which is a broader umbrella of abnormal involuntary movements, right?
Yes, they can look jerky, writhing, or choreic, meaning dance-like.
And these movements severely impact a child's positioning and their fine motor function.
If a child's muscles are constantly, involuntarily fighting against each other due to dystonia, seating them safely in a supportive wheelchair becomes incredibly difficult.
Trying to grasp a spoon or reach for a toy becomes an exhausting battle against their own basal ganglia.
Yet putting them on a high dose of valproic acid won't fix a basal ganglia motor loop issue.
It just won't. Then we have the behavioral imposters, the stereotypics.
These are highly repetitive, rhythmic, and often purposeless movements.
Right, and in the context of the profound intellectual disability common in PURA syndrome, children frequently engage in intense self-soothing or sensory-seeking behaviors.
We see rapid hand flapping, intense body rocking, or severe hand biting and hand sucking.
And if a parent is constantly hypervigilant for myoclonic jerks, a sudden violent burst of hand flapping can easily trigger a false alarm.
Absolutely. But stereotypies are typically driven by environmental factors, excitement, anxiety, or sensory understimulation.
They aren't driven by an unprovoked cortical discharge.
Right.
And we also have to account for the highly delicate cranial nerves controlling the eyes. Ocular abnormalities are a massive red herring.
The ocular muscles require exquisite neurological coordination to track objects smoothly.
And in PURA syndrome, that coordination is frequently absent.
Yes, we see dysconjugate gaze, where the eyes fail to move in tandem.
And nystagmus, which is a rapid, involuntary, repetitive jittering or beating of the eyes.
During a true seizure, a child's eyes might deviate sharply to one side or stare fixedly.
But if a child has baseline nystagmus, their eyes are constantly jittering.
So a caregiver might look at those eyes and constantly fear the child is locked in a continuous low-grade seizure state.
When in reality, it is a chronic muscular and cranial nerve deficit.
Right. But of all the impostors detailed in the literature, the most insidious, the one that's considered a clinical hallmark of PURA syndrome, is the pathological startle response.
Oh, this one causes immense confusion.
Because it visually mirrors a massive myoclonic jerk perfectly.
Right. If you are in the kitchen and a heavy pot drops onto the tile floor, and your child in the adjacent room violently jerks their entire body in response, you have to determine the biological root of that movement.
Was a loud noise a trigger for an actual electrical seizure, or was it a pathological reflex?
If a door slams and my child suddenly jerks, is that a myoclonic seizure triggered by noise or a pathological startle?
To dissect this, we have to look at the brainstem, specifically the reticular formation.
The reticular formation acts as the brain's sensory gatekeeper.
Exactly. When a sudden loud noise occurs, the brainstem registers it instantly and triggers a microscopic startle reflex to prepare the body for potential danger.
But in a neurotypical brain, the cortex immediately assesses the noise, realizes it's just a dropped pot, and sends an inhibitory signal back down to the brainstem to dampen the reflex.
And that dampening system relies on rapid, efficient neural communication.
Which we know is compromised in PURA syndrome. The Pur-alpha deficiency means those neural pathways are poorly insulated and structurally weak.
Precisely the issue. The dampening signal from the cortex is too weak, or it arrives too late.
So the brainstem's reticular activating system is left entirely uninhibited.
And instead of a minor flinch, the child experiences a violent whole-body spasm.
The reflex is exaggerated to pathological levels.
Yes, and it is incredibly difficult for the child's nervous system to return to a baseline state of calm.
They might remain agitated, rigid, or distressed for an extended period after the trigger.
The distinction lies entirely in the predictability of the trigger.
Right. A true epileptic seizure is an unprovoked cortical storm. It happens regardless of what is going on in the room.
But a pathological startle is a reflex issue locked entirely to sensory input.
If the sudden jerking consistently correlates with a loud dog barking, a door slamming, or even an unexpected touch, you are dealing with a broken sensory gatekeeper, not epilepsy.
And if we connect this to the bigger picture, the treatment protocol shifts entirely.
You don't use anticonvulsants, you use environmental engineering.
Exactly. You modify the acoustic environment with sound dampening materials.
You utilize noise-canceling headphones in public spaces.
And you institute a strict protocol of visually and verbally warning the child before initiating physical contact.
But even with a deep understanding of these mechanisms, the naked eye of a parent or a clinician is inherently fallible.
You cannot see the electrical activity of the cortex.
You cannot look at a twisting arm and definitively say, that is basal ganglia dystonia, not a focal seizure.
Because clinical observation is flawed, the medical literature mandates a definitive diagnostic solution.
The video EG.
Yeah.
The video EG is the ultimate arbiter of truth in this diagnostic landscape. It bridges the gap between what the body is doing and what the brain is broadcasting.
Let's delve into exactly how this works.
I look at the video EEG as the simultaneous synchronization of a high-definition security camera with a highly sensitive biological seismograph.
That is an incredibly accurate way to conceptualize it.
So what's actually happening during the test?
The EEG component involves precisely measuring the microelectrical currents of the cerebral cortex.
The technician uses the International 1020 system to glue a vast array of electrodes directly to the child's scalp.
And these electrodes detect the tiny electrical fluctuations generated by the synchronized firing of millions of neurons.
This data is fed into an amplifier and displayed as a continuous series of waveforms on a monitor.
That's your seismograph looking for the earthquake.
But the challenge with PURA patients is that keeping those electrodes glued to the head of a child with severe sensory processing issues, intellectual disability, and pathological startle responses is an extreme logistical hurdle.
Oh, absolutely. They will try to pull them off.
They will sweat, they will chew, they will grind their teeth, and all of those muscle movements create massive electrical artifacts on the EEG trace.
And those artifacts look exactly like the chaotic spikes of a seizure.
Which is why a standard 20-minute routine EEG is often useless for this population.
You really need prolonged telemetry.
You admit the child to an epilepsy monitoring unit for 24, 48, or even 72 hours.
And you pair that continuous EEG recording with a time-lock, high-definition video camera.
The video captures every physical movement, every eye twitch, every hand flap.
So when the event happens, when the child suddenly stiffens and their arm jerks violently upward, the diagnostic guesswork is eliminated.
The neurologist reviews the data. They go to the exact millisecond on the video recording where the arm jerks.
Then they look at the synchronized timeline on the EEG waveforms for that exact same fraction of a second.
It is a binary objective test.
Yes. If the video shows a violent physical spasm, but the EEG waveforms during that exact second remain perfectly organized and show baseline background activity.
You have captured an impostor.
Exactly. You have proven definitively that the brain's cortex was not surging.
It was a pathological startle or a burst of dyskinesia, but it was not epilepsy.
However, if the moment the arm jerks, the EEG trace erupts into a high-amplitude chaotic storm of spike and wave discharges.
You have confirmed the seizure.
The video EEG is the only tool that gives you the biological proof required to safely prescribe or withhold heavy neurological medications.
But knowing it's a seizure from an EEG is only half the battle, right?
Sadly, yes.
If a parent is watching that monitor confirm the worst, their immediate next thought is, okay, how do we stop it?
And that's where the literature regarding medical management becomes incredibly grim.
The reality is that treating confirmed epilepsy in PURA syndrome is a brutal exercise in managing drug resistance.
The term heavily utilized across all clinical studies for this condition is refractory.
Meaning PRA-related seizures stubbornly resist standard pharmacological intervention.
Right. To understand why, we have to contrast it with typical focal epilepsy.
Let's do that. If a patient has a seizure disorder caused by a localized brain injury, say a scar from a childhood head trauma or a tiny benign tumor, what happens?
In those cases, the seizures originate from that one specific cluster of damaged cells.
And neurosurgeons have a highly effective structural solution for that: focal resection.
Right. They open the skull, map the brain, and surgically remove or disconnect that tiny, misfiring piece of tissue.
Once the bad wiring is removed, the seizures generally stop.
But the generalized nature of the Pur-alpha deficiency makes surgical resection entirely impossible.
Completely impossible.
Because the genetic deletion happened at the embryonic stage, the deficiency is ubiquitous.
Every single neuron across all 4 lobes in both hemispheres lacks the critical Pur-alpha protein.
The structural instability is baked into the entire network.
There is no single focal point to cut out. The entire grid is faulty.
Therefore, the most definitive cure for epilepsy surgery is fundamentally off the table for the PURI population.
Which isolates the treatment entirely to chemical management.
You are forced to rely on anti-seizure medications, or ASMs.
But because the instability is so severe, monotherapy using a single drug rarely achieves seizure freedom.
Neurologists are quickly forced into polytherapy.
And polytherapy is a complex pharmacological balancing act.
It really is. You are prescribing multiple, powerful medications in combination.
hoping that attacking the electrical storm from multiple mechanistic angles will work.
Right. You might use a sodium channel blocker to slow down the firing rate of the neurons, combined with a GABA enhancer to boost the brain's natural inhibitory calming signals.
But the pharmacodynamics of layering these neuroinhibitors are devastating to the child's quality of life.
Yes, these drugs do not just target the seizure activity, they suppress the entire central nervous system.
You are taking a child who already suffers from central hypotonia, profoundly low muscle tone, and severe cognitive delays.
And you are saturating their brain with heavy sedatives.
The side effects, extreme lethargy, loss of appetite, liver toxicity, and behavioral regression often become as debilitating as the seizures themselves.
And when polytherapy fails to control the seizures, or when the systemic toxicity of the drugs becomes too dangerous, the medical team must pivot.
To alternative neuromodulation or metabolic therapies.
Yes, like the vagus nerve stimulator, or VNS.
Explain how the VNS works.
It involves surgically implanting a pulse generator in the chest wall, with a wire wrapped around the left vagus nerve in the neck.
It acts like a pacemaker for the brain, right?
Exactly. Sending regular, mild electrical impulses up into the brainstem to disrupt abnormal synchrony in the cortex.
It is palliative, rarely curative, but it can reduce seizure frequency without adding more chemical sedation.
But the intervention that requires the most intense biological scrutiny is metabolic therapy, primarily the ketogenic diet.
Here's where it gets really interesting. This brings us back to that harrowing 2024 case study we discussed at the very beginning.
The ketogenic diet is not a lifestyle choice in this context. It is a hardcore, systemic biochemical overhaul.
Let's look at the underlying mechanics of why it was attempted on this 11-year-old boy suffering from 30 flexion spasms a day.
Under normal conditions, the human brain relies almost exclusively on glucose sugar for its energy metabolism.
But the ketogenic diet forces a radical metabolic shift.
By enforcing a diet that is extremely high in fats and severely restricted in carbohydrates, you starve the body of glucose.
The liver is forced to break down fatty acids through a process called beta oxidation to produce ketone bodies.
And these ketones cross the blood-brain barrier and become the brain's new primary fuel source.
And while the exact mechanism isn't entirely mapped out, we know that metabolizing ketones fundamentally alters the brain's neurochemistry.
It increases the production of GABA, the calming neurotransmitter.
And it alters the function of ATP-sensitive potassium channels.
Effectively hyperpolarizing the neurons and making them much harder to fire.
It raises the seizure threshold.
And in the case of our 11-year-old patient, that metabolic shift worked brilliantly at first.
The ketones stabilized his faulty biological grid.
Yes. Within 2 months, his seizure diary showed a massive 50% reduction in the violent flexion spasms.
Going from 30 drops a day to 15 is a monumental improvement in his physical safety and cognitive availability.
And the diet also provided a bizarre, yet massive, secondary benefit.
The complete cessation of his coeluria.
Right.
For those listening, coeluria, or chronic severe drooling, is a major issue in PURA syndrome.
It's due to the combination of low facial muscle tone, poor swallowing coordination, and autonomic dysfunction.
The constant drooling causes severe skin breakdown around the mouth and neck.
It requires constant bib changes and poses a chronic aspiration risk.
The fact that the ketogenic diet resolved this entirely within 1 month was a huge victory for his daily comfort.
But then, at the 3-month mark, the fatal flaw in applying standard metabolic therapies to a multi-system genetic syndrome revealed itself.
The boy crashed.
He developed profound weakness and systemic fatigue.
Let's dive deeply into the biochemistry of why his body failed. It wasn't just that he was tired of eating fat, right?
No, his internal organs were buckling.
This is the crucial takeaway for the medical management of PURA syndrome.
The pur-alpha protein isn't just missing in the brain. It is ubiquitously expressed.
It is missing in the skeletal muscles, in the heart, and critically, in the liver.
To maintain a state of ketosis, the liver must operate at absolute peak metabolic efficiency.
Constantly performing beta oxidation of fats.
But a liver lacking pur-alpha doesn't have the cellular infrastructure to sustain that level of metabolic overdrive indefinitely.
Exactly. The genetic deficiency compromises the systemic, metabolic, and autonomic systems.
The liver's enzymes likely couldn't keep up with the demand,
The cellular energy production in his muscles began to fail.
leading to that profound, unrelenting weakness.
A medical team attempted to salvage the diet with aggressive fluid therapy and macronutrient adjustments.
But the biological reality of PURA syndrome won out.
His body simply could not tolerate the metabolic strain of ketogenesis.
They had to abandon the diet to prevent total systemic collapse.
The lesson there is chilling but vital for everyone listening.
Alternative therapies like the ketogenic diet or VNS can offer incredible life-altering breakthroughs.
But they are not silver bullets, and they carry massive systemic risks.
A parent cannot simply initiate a low-carb diet at home.
No, it requires hypervigilant, continuous clinical monitoring.
You need a dedicated neurology and dietetics team constantly running blood panels, checking liver enzymes.
Monitoring bone density and watching their hydration like a hawk.
Because ultimately the hard truth of PURA-related epilepsy is that no single medication, no implanted device, and no highly engineered diet is going to provide a guaranteed permanent shield.
The electrical instability is just too deeply ingrained in the biology. Breakthrough seizures are an unavoidable reality.
Which means relying entirely on prevention is a failing strategy.
If you know the storm is eventually going to break through the seawall, your focus must shift to how you manage the floodwaters when they arrive.
Yes, you must have a mathematically precise, medically robust, and written emergency protocol.
This protocol has to function seamlessly in your living room at 2 a.m.
And more importantly, it has to function in a classroom setting where you, the expert caregiver, are not present to supervise.
So let's build that protocol. The foundation begins with defining the absolute worst-case scenario.
What is the ultimate medical emergency we are trying to prevent when a seizure breaks through?
We are fighting to prevent status epilepticus.
Status epilepticus is the red line.
It is the scenario where the brain's inhibitory mechanisms fail entirely and it forgets how to turn the electrical storm off.
Clinically, status epilepticus is defined as a continuous seizure lasting longer than 5 minutes.
Or a series of consecutive seizures where the child does not fully regain baseline consciousness between the events.
The 5-minute mark isn't just an arbitrary number chosen for convenience.
No, it represents a critical shift in the brain's neurochemistry.
During the first few minutes of a seizure, the brain is actively releasing GABA to try and stop the firing.
But as the seizure drags on, the GABA receptors on the neurons actually begin to retreat into the cell they internalize.
At the same time, the excitatory NMDA receptors move to the surface.
Exactly. The brain actively becomes more prone to seizing the longer the seizure lasts.
The pharmacology flips.
And as the electrical storm rages past 5 minutes, the metabolic consequences become dire.
The brain's demand for oxygen and glucose massively exceeds the supply.
This localized hypoxia and massive release of excitatory neurotransmitters like glutamate leads directly to excitotoxicity.
Excitotoxicity being the actual physical death of neurons.
Prolonged status epilepticus causes permanent, irreversible brain damage, and it carries a significant risk of mortality.
Because the stakes are that high, your school protocol cannot be vague.
It cannot rely on the subjective judgment of a substitute teacher.
It cannot say, observe the child and call the parents if they look unwell.
No, it must be a strict, conditional logic tree.
Your protocol must explicitly define the timeline for administering rescue medications.
Rescue meds such as buccal midazolam applied to the gums or rectal diazepam.
Right, these are fast-acting benzodiazepines designed to flood the brain with GABA and violently hit the brakes on the electrical storm.
The protocol should dictate. If a generalized tonic-clonic seizure reaches exactly 3 minutes in duration, administer the prescribed dose of rescue medication immediately.
And it must outline the failure condition.
If the seizure reaches the 5-minute mark, or if the child's lips turn blue indicating compromised airway and hypoxia at any point, call emergency services immediately.
You remove the burden of decision-making from the panicked educator. The protocol makes the decision for them.
But a truly robust emergency protocol doesn't just react to the seizure, does it?
No, it proactively attacks the environmental and physiological factors that lower the seizure threshold in the first place.
This is where the highly specialized guidelines from orphan anesthesia become an invaluable tool for daily caregiving.
Well designed for surgeons, these guidelines map out exactly what stresses a PURA patient's fragile systemic biology.
We can isolate 3 major external triggers that cause seizures to break through the medication barrier: hypoventilation, pain, and stress.
Let's systematically break down how to build protocols around these, starting with hypoventilation.
Hypoventilation simply means inadequate breathing, leading to a buildup of carbon dioxide in the blood and a drop in oxygen reaching the brain.
And oxygen is the primary fuel the brain uses to maintain its electrical stability.
The problem in PURA syndrome is central hypotonia.
The muscles of the chest wall, the diaphragm, and the airway are fundamentally weak.
Furthermore, many patients suffer from central sleep apnea or hypopneas, where the brainstem simply forgets to send the signal to breathe deeply.
So imagine a child is sitting in a classroom wheelchair.
And their low muscle tone causes them to slowly slump forward over the course of an hour.
They are physically compressing their own lungs.
Their tidal volume drops, their oxygen saturation slowly dips from 98% to 92%.
The brain senses that localized hypoxia, the metabolic stress spikes, and the fragile electrical grid short circuits.
A seizure breaks through.
To mitigate this, your school and home protocol must mandate strict postural monitoring.
Educators must be trained to recognize the signs of respiratory fatigue.
The child must be repositioned regularly to ensure maximum lung expansion.
Furthermore, during times of common respiratory illnesses, even a basic cold, the protocol must escalate.
Secretions pool in a hypotonic airway, further reducing oxygen exchange.
Increased vigilance, the use of pulse oximeters to measure oxygen saturation during naps, and aggressive airway clearance are critical biological defenses against hypoventilation-triggered seizures.
The second major trigger we extracted from the perioperative guidelines is pain.
This is an incredibly insidious trigger because of the massive communication barrier inherent in PURA syndrome.
It is perhaps the most difficult trigger to manage.
The vast majority of children with PURA are entirely nonverbal. They cannot articulate their internal state.
To compound the danger, their altered neurological wiring often results in atypical sensory processing.
They might have a dangerously high pain tolerance, or their physiological response to severe pain might not look like typical distress.
Right. If a typical child develops a severe ear infection or intense gastrointestinal cramping or a subluxation of their hip joint, what do?
They cry out, they point to the area, they tell you it hurt.
But a child with PRA might just become unusually quiet, or their baseline heart rate might elevate slightly.
But internally, that unmanaged pain is causing a massive release of stress hormones like cortisol and adrenaline.
Those hormones dramatically lower the seizure threshold.
The pain becomes the spark that ignites the cortical storm.
Which means we cannot rely on self-reporting.
If unmanaged pain is a primary seizure trigger, caregivers and educators must have a standardized, objective tool to detect it.
Your protocol must mandate the use of the FLACC scale for all nonverbal assessments.
The FLACC scale is an observational behavioral pain assessment tool. FLACC is an acronym, right?
Yes. Face, legs, activity, cry, consolability.
It forces the observer to look past the lack of verbal communication and analyze the biological signs of distress.
Let's walk through exactly how an educator would use this.
Each of the 5 categories is scored from 0 to 2.
Let's take the face category. A score of 0 means a relaxed, neutral expression.
A 1 might indicate occasional grimacing or a furrowed brow.
And a 2 is a constant frown, a clenched jaw, or a quivering chin.
For legs, a 0 is normal, relaxed positioning.
A 1 is restless or tense movements.
A 2 involves legs drawn up tightly to the chest or rigid kicking, which is a classic sign of severe abdominal pain.
Activity measures their general state. 0 is lying quietly or moving easily.
1 is squirming, shifting back and forth, or general tenseness.
2 is arched, rigid posturing or severe jerking.
Cry doesn't just mean tears. 0 is no cry.
1 is moans, whimpers, or occasional complaints.
2 is steady crying, screaming, or a constant distressed groaning.
And finally, consolability. Can the child be calmed?
0 is relaxed. 1 is distracted or reassured by a favorite toy or gentle touch.
2 is completely inconsolable, resisting any comfort.
The educator observes the child for a few minutes, scores each category, and tallies the number.
If a nonverbal child suddenly scores a 7 on the FLACC scale, the protocol dictates that they are in significant pain, regardless of whether they are shedding tears.
Identifying and treating the source of that pain, whether it means administering an analgesic, adjusting a tight orthotic brace, or relieving trapped gas, removes the physiological stressor before it can trigger a massive status epilepticus event.
It is a proactive rather than reactive approach.
The third major trigger highlighted in the literature is stress, specifically physiological stress related to temperature.
The guidelines warn heavily about autonomic dysregulation in this patient population.
The autonomic nervous system is the body's automatic control center. It manages the heart rate, digestion, and crucially body temperature, without us having to think about it.
The thermostat for this system is located deep in the brain, in the hypothalamus.
And because the Pur-alpha deficiency impacts the development of these deep brain structures, the hypothalamus often fails to regulate core body temperature effectively.
Patients with PURA are highly susceptible to sudden, profound drops in body temperature hypothermia,
This can happen rapidly in a heavily air-conditioned classroom,
or after a bath when the water evaporates from their skin.
or simply because they are inactive in a wheelchair and not generating internal muscle heat.
Being cold isn't just uncomfortable. It is a severe physiological stressor.
When the core temperature drops, the body panics. It initiates a massive sympathetic nervous system response to try and generate heat.
It triggers intense shivering, which rapidly depletes the muscle's energy stores.
And it causes severe peripheral vasoconstriction, clamping down the blood vessels in the arms and legs to force warm blood to the core.
This systemic panic heavily taxes the brain's regulatory systems, stealing the energy it needs to maintain electrical stability.
Therefore, your school and home protocol must prioritize active thermoregulation.
You are managing the external environment to protect the internal autonomic system.
The protocol should explicitly dictate monitoring the ambient temperature of the classroom.
It should require the availability of heated blankets, heated wheelchair pads, and extra layers of clothing.
Educators must be trained to touch the child's extremities regularly to check for poor perfusion and cold skin.
By keeping the child's body in a state of thermal neutrality, you eliminate a major biological trigger for breakthrough seizures.
So, we have built a protocol that mandates exact timing for rescue medications to stop status epilepticus.
We have instituted the FLACC scale to hunt down hidden pain.
We have implemented postural checks to prevent hypoventilation, and we are aggressively managing the ambient temperature.
But there is one final, absolute, non-negotiable rule of the emergency protocol.
And it concerns the continuity of the pharmacological shield itself.
The absolute rule is medication continuity. The daily doses of the prescribed anti-epileptic medications must never, under any circumstances, be missed.
Not a single dose. The margins are simply too thin.
They are non-existent. These powerful neurological drugs are carefully calibrated by the neurologist based on their specific half-lives.
The goal is to maintain a steady, continuous concentration of the drug in the bloodstream to artificially enforce the brain's inhibitory signals.
If a single dose is missed or administered several hours late, the blood concentration drops precipitously.
This doesn't just return the child to their baseline risk. It opens the door for withdrawal seizures.
The brain, suddenly deprived of the chemical brakes it relies on, rebounds into a state of hyperexcitability.
The resulting seizures are often exponentially more severe and harder to stop than their typical baseline events.
But the reality of daily life, and particularly the medical realities of PURA syndrome, inevitably forces situations where a child cannot take their oral medication.
The most dangerous yet common scenario involves surgery.
Children with the syndrome frequently require complex orthopedic surgeries to correct severe scoliosis or to repair dislocated hips caused by their central hypotonia.
Before these procedures, the surgical team enforces a strict NPO order nil per S, meaning nothing by mouth, for up to 12 hours to prevent aspiration while under anesthesia.
You cannot give them their oral pills or liquids.
This is exactly why the orphan anesthesia guidelines are a critical tool for advocacy.
Without a specialized protocol, a standard surgical team might simply hold the morning dose of the seizure medication, assuming it is safe to wait until the child wakes up.
Your medical protocol must strictly, aggressively dictate to the surgical team that intravenous IV antiepileptic substitution is foreseen, calculated, and administered while the child is fasting.
If the neuroinhibitor cannot go into the stomach, it must go directly into the vein.
Because the general anesthesia itself isn't necessarily the spark that ignites the seizure, right?
Generally, no. Most anesthetic induction agents actually profoundly depress cortical activity.
The true danger zone isn't while they are intubated on the operating table. The danger is the recovery room.
Let's paint that physiological picture. The child wakes up from a massive orthopedic surgery.
Their body is registering the intense, acute pain of the surgical incisions.
They are shivering violently because operating rooms are kept notoriously cold, triggering that autonomic dysregulation we discussed.
Their respiratory drive is weak from the lingering effects of the anesthesia, leading to hyperventilation.
And if the EV substitution was missed, they have zero anti-seizure medication circulating in their bloodstream.
It is the absolute perfect storm. Every single trigger pain, cold, hypoxia, and medication withdrawal is hitting the fragile biological grid simultaneously.
That is a guaranteed recipe for catastrophic post-operative status epilepticus.
Advocacy for that 5A substitution is a matter of life and death.
Furthermore, the protocol should use the guidelines to warn the anesthesiologist about specific intraoperative risks.
The guidelines explicitly flag the use of sevoflurane.
Yes, sevoflurane is a very common volatile anesthetic gas.
However, in certain susceptible pediatric populations, particularly those with profound underlying genetic encephalopathies, sevoflurane has been shown to alter gap junctions and specific ion channels in a way that promotes epileptiform activity on an EEG.
The protocol should advise the anesthesiologist to utilize alternative maintenance agents, like propofol infusions, to avoid lowering the seizure threshold chemically.
The guidelines also highlight the mechanical risks of the ventilator itself. The protocol must warn the anesthesiologist to avoid hyperventilation during the surgery.
When an anesthesiologist manually breathes for a patient, overventilating them, breathing too fast or too deep, rapidly blows off the carbon dioxide in the blood.
While we know high CO2 is bad, driving the CO2 too low causes massive cerebral vasoconstriction.
The blood vessels in the brain clamp down tight, severely reducing blood flow and oxygen delivery to the cortex.
That sudden, localized hypoxia is a massive trigger for cortical electrical storms. The ventilation must be meticulously balanced to maintain normal CO2 parameters.
Taking all of this in learning the cellular mechanisms of Pur-alpha, teaching a substitute teacher the intricacies of the FLACC scale.
Demanding pharmacological substitutions from a daunting surgical team fighting constantly for temperature and posture control, it is an incredibly heavy burden.
It feels overwhelming to process the sheer volume of biological vulnerabilities. I know it does.
But understanding these vulnerabilities is the ultimate act of empowerment. You are taking a terrifying, chaotic neurological storm and breaking it down into its mechanical components.
You are turning abstract fear into concrete, actionable steps.
It allows you to create a scientifically validated zone of safety around your child in an inherently unpredictable world. We have covered a monumental amount of ground in this deep dive.
We really have. We started by tracing the seizures back to their genetic root, understanding how the missing Pur-alpha protein leaves the brain's electrical grid fundamentally uninsulated and prone to widespread surges.
We examined the timeline of vulnerability, recognizing that the risk spans from the neonatal period into adulthood.
We meticulously mapped out what those electrical surges look like in reality, from the lightning-fast pops of myoclonic jerks and the silent hijacking of absent seizures,
to the severe physical trauma of generalized tonic-clonic convulsions and the devastating developmental erasure caused by Lennox-Gastaut syndrome.
We brought the impostors into the light. We learned how to differentiate the deep basal ganglia dysfunction of dystonia and the behavioral repetition of stereotypes from actual cortical firing.
We broke down the mechanics of the reticular formation to understand why a slammed door triggers a violent pathological startle response and why environmental engineering is the only treatment.
We highlighted the absolute necessity of demanding a prolonged video EEG to definitively match the physical movement to the electrical seismograph, preventing toxic misdiagnoses.
We faced the brutal clinical reality of drug-refractory epilepsy, exploring the pharmacodynamics of polytherapy, and dissecting the systemic metabolic failure that can occur when a PURA patient's fragile internal systems are forced into radical interventions like the ketogenic diet.
And finally, we used the orphan anesthesia guidelines to construct a biological fortress, a rigid emergency protocol that uses exact timing to prevent status epilepticus.
Utilizes the FLACC scale to hunt down hidden pain, aggressively manages temperature and posture, and demands absolute pharmacological continuity during the intense stress of surgery.
So if we look back at the entirety of this medical landscape,
So what does this all mean for the daily life of a caregiver?
it means that while the genetic reality of PURA syndrome is fixed, you cannot currently enter the nucleus of the cell and force the production of the missing Pur-alpha protein today. You have immense, profound power in managing the environment the child lives in.
You have the knowledge and the clinical guidelines to actively protect your child from the physiological triggers that exacerbate their condition.
You are the architect of their biological safety.
And while you're exhausting yourself managing that environment today, I want to leave you with a final, deeply provocative thought about what is coming tomorrow.
We dug into the research pipeline heading toward 2026, and the developments occurring right now at the molecular level are staggering.
The scientific community is no longer just observing the damage, they are actively manipulating the biology.
There is a landmark international collaboration occurring right now utilizing the Nobel Prize-winning CRISPR-Cas9 gene editing technology.
Scientists at the Florey Institute in Australia have successfully engineered a new knockout mouse model.
They have used CRISPR to literally snip out the specific genetic sequence, creating living mice that perfectly mirror the exact PRA deficiency seen in human patients.
Why is a mouse model such a monumental game changer for a rare disease?
Because for the first time in history, researchers are not guessing. They aren't trying to extrapolate data from general epilepsy studies.
They have a living biological replica of a PRA brain.
They can actively study the exact molecular pathways that lead to this specific drug-refractory epilepsy.
They are currently using these models to test highly experimental gene overexpression therapies and to repurpose existing pharmacological molecules directly on a brain that mimics your child's brain down to the cellular level.
So here's the question for you to mull over as you continue this exhausting journey.
We've spent this entire deep dive focused on mitigation. We've talked about how to spot the seizures from the outside, how to patch the roof, and how to sandbag the doors against the electrical storm.
But with these CRISPR-engineered models, providing a real-time map of the pathology, how close are we to an era where we stop treating the electrical storm after the lightning strikes?
How close are we to a paradigm shift where we utilize precise genetic engineering to actually go into the neurons, replace the missing couriers, and fix the physical wiring of the brain at its most fundamental level?
The trajectory of the science is shifting definitively. We are moving from the era of symptom management toward the dawn of fundamental genetic correction.
And that is a future worth holding on to. I want to warmly thank you for joining us on this deep dive.
It's been an absolute privilege.
I strongly encourage you to take this knowledge, take these clinical realities, and share them directly, forcefully, with your child's care team.
Bring up the specific mechanics of the FLACC scale. Ask your neurologist about the necessity of prolonged video EEGs.
Demand the pharmacological substitutions before any surgical procedure. The diagnostic landscape of rare genetics might be murky, and that proverbial X-ray machine might be broken.
But you do not have to navigate these waters blind anymore.
You have the map. Take care of yourselves, advocate fiercely, and we'll see you next time.